go ahead and get started with the what is a really exciting day for us, which is the second annual Jim Goodnight Lectureship. As most of you know, but some of our newer residents, Dr. Goodnight was the previous chair of the Department of Surgery and led a tremendous transformation and contributed mightily to the development of the UC Davis Cancer Center. And we, as you know, are one of the comprehensive cancer centers, which is the highest designation available from the NCI, and we are pleased to have been able to raise the funds to develop this lectureship in his name. So with that, I will turn it over to our Chief of Surgical Oncology, Dr. Bold, to introduce our visiting professor. Thanks, Rick.
So it's really an honor and a privilege to introduce Dr. Faries. Dr. Faries got his medical education at Cornell, residency at Penn, 2 years, I think, senior to Bob Cantor in residency, and then went on to his fellowship at John Wayne Cancer Institute under the leadership of Don Morton and Armando Giuliano, really pioneers in the field of melanoma that has subsequently guided his career. Mark has participated in a lot of national activities related to melanoma, numerous publications. He sits on the AJCC Staging Council. So this is the group that actually defines how we develop staging systems, and his impact is really felt in that leadership roles in our surgical oncology and our international melanoma community. And it is truly a privilege and honor to have Dr. Faries here as a Goodnight lecturer to describe his work in the advancement of this disease. Dr. Faries.
Thanks very much. It's a real honor to be here, particularly given the name for the lectureship for Dr. Goodnight. My mentor, Don Morton, was obviously influential for many things in his career, but the thing that he was always most proud of were the people that he trained, and that would be what he would brag about despite all the other things that he did. And one of the superstars within that list of alumni from Don Morton's training was Dr. Goodnight. So to be here, to be part of this lectureship is really an honor for me. So thank you for having me. Disclosures, nothing I think that is of any relevance to what we're talking about today. What I will talk about, we'll first cover the MSLT-II trial. So many are familiar with that. Results came out about 6 months ago or so from that, and it's an ongoing trial. So we're talking about the current status of that, and then provide some context to that trial in the larger scope of melanoma and of lymph nodes in surgery, oncologic surgery in general. And there are three parts to that. The sort of origins of this issue and the controversy, where it was obvious that lymph nodes were a critical link in the chain of how tumors spread, but then getting into the actual history and the data that came out that didn't really fully support this conjecture that lymph nodes were essential to the spread of cancer, and then try and bring it around to what I think are some reasonable interpretations and conclusions, at least with the data that we have. So the MSLT-II trial was an international randomized phase 3 trial that was asking the question of, do you need to do a completion lymph node dissection in patients that have had a melanoma, a sentinel lymph node biopsy with a metastasis detected in the sentinel node? And the reason that was a reasonable question to ask is that the vast majority of those patients that have metastases in the sentinel nodes, the remainder of the lymph nodes are clear. And so they go through the somewhat larger operation, and you just find out that the rest of the lymph nodes were negative. With you look at MSLT-I data, or data from the John Wayne database, or even a series that Alistair Cochrane, our pathologist, looked at, where they did immunohistochemistry on all of the remaining nodes taken out in completion dissections. The vast majority of the time, the remainder of those lymph nodes are clear. If you look at the other side of the coin, and you look at patients that have metastases in non-sentinel lymph nodes, they actually do fairly poorly. So this is our series. There are a number of other series that show just the same thing, that if you have the remainder of your nodes, the non-sentinel nodes are negative, you do relatively well. If you have any involvement of any non-sentinel lymph nodes, then your prognosis is significantly worse. And if you overlay onto this the AJCC 7th edition survival curves for stage 3 melanoma, the 3As are all the non-sentinel node negatives. And if you have any involvement, even not clinically detected involvement of your non-sentinel nodes, you do just as poorly as patients that have palpable stage 3B or 3C disease. And so you could ask the question, would they really gain anything by doing the surgery early on, or could you do just as well if you wait and operate on them later? So there was equipoise to ask this question. Advantages of the surgery: you do get cancer out in about 10 to 20% of the patients. You get staging information, which you'll see in a bit is actually valuable, important information from the completion dissection. At the time, it was a requirement for all of the adjuvant clinical trials, so that was another rationale for doing it. And you improve regional control, but you get that at the cost of the morbidity of dissections in which most of the time they are negative. This question was, we tried to ask this question retrospectively at our institution and at others as well, and I think it's a good illustration of why retrospective studies can't definitively answer many of these questions. So when you look at a series from Memorial and a series from John Wayne, if you look at either recurrence-free survival or at nodal recurrence-free survival, there's obviously a significant impact on doing the dissection. You take out the nodes before they have a chance to recur. But if you look at melanoma-specific survival, sort of the long-term impact of that intervention, you get the opposite results depending on where you ask the question. So if you were in New York, you would rather have your lymph nodes left in place because you survived better in that instance for reasons that are somewhat hard to explain. Whereas if you're in California, well, you want your nodes out, and you'll survive better if you do it that way. So there's not a great reason why the studies would have come out in opposite directions, but that's, as Howard Cosell says, that's why they play the game. And so this is why a prospective clinical trial needed to be done. The MSLT-II trial consisted of 2 phases. So there's a screening phase that took place for patients prior to their sentinel node biopsy. And if you were positive on that, then you could enroll in the randomization phase. The screening phase assessment of the sentinel nodes had standard pathology, and then it had a multi-marker RT-PCR assay on the paraffin-embedded sentinel nodes. And if you were positive by that assay, then you were also eligible to enroll in the randomization phase if you chose. You could also get into the trial if you had a positive sentinel node from outside of the screening phase and enrolled at that point. The goal for randomization was 1926. We exceeded that just a little bit, and stratified based on established risk factors. And then patients were assigned 1-to-1 to either immediate completion lymph node dissection or observation of the nodal basin with ultrasound as a way of facilitating early discovery of recurrences within the basin. The primary endpoint comparison was melanoma-specific survival between the 2 randomized groups. Secondary endpoints, disease-free survival, regional disease-free survival, distant disease-free survival, et cetera. There's also a plan to examine a comparison of what we call latent subgroups, so the patients that had non-sentinel node involvement discovered either at the completion dissection or based on recurrence in the basin. We'll get to that a little bit, that sort of latent subgroup analysis that was done for the first MSLT trial and why that was an important component of that, so there's a thought to do that here. As well as quality of life, an examination of this RT-PCR assay to see how prognostic it actually is, and then ultrasound. Patients in the screening phase got ultrasounds prior to their sentinel node biopsy to see how good ultrasound is at detecting sentinel node metastases. There have been proposals that ultrasound could potentially replace sentinel node, and then ultrasound is a component of the follow-up of these patients that are in nodal observation to see how much it contributes to detection of any recurrences. It's a worldwide trial, 63 centers that were involved. The first MSLT trial had leaned very heavily on Sydney. About half the patients came from Sydney, Australia. This trial was more broadly distributed across the planet, with North America actually contributing the largest number, but couldn't have been done without the participation of all of those sites. The result was published in June, and interesting things to note about the demographics of the population that were in the trial. One is relatively on the thicker end of primary tumors, so T3 and above in general. A fairly substantial proportion of them had ulcerated tumors, just under 40% for both arms. And then, importantly, the size of the sentinel node metastases was small. So smaller than was the case in MSLT-I, and some of that was based on investigators sort of choosing who they thought were good candidates for the trial, probably in part based upon that information. But 2/3 of the patients had metastases in the sentinel node where the largest diameter of the metastasis was less than 1 millimeter. And then the last bit, in terms of any adjuvant therapy that patients got in the trial, the arms were about equal, and almost nobody got adjuvant therapy because at the time there was really nothing from a medical standpoint. Interferon was available, but not many people chose to take the offer for interferon up. This is the headline news. So the primary endpoint of the trial, no difference in melanoma-specific survival based upon early intervention with completion lymph node dissection. Prior to releasing the information, the DSMB went to our statisticians to say, is there a chance that if you have more follow-up that you'll get to a positive result at some point? And essentially the answer was no. Almost certainly no matter, we'll continue to follow these patients, but almost certainly no matter how much follow-up we have, this will not turn into a positive result in either direction. One of the issues with the trial, and one of the potential criticisms that we've seen, is that we have this group in the trial that was only positive in their lymph nodes based upon an RT-PCR assay. So since there's no difference, there might be a suggestion, well, that group was not really meaningful and it diluted out a therapeutic effect in the pathology positive, the real positive nodes. So when we present the data, we present it also split up into pathology positive and PCR positive. And so the red and blue lines are the path positive group, and again, no difference there in terms of impact of the treatment. This is supported by another prospective trial done by the German cooperative group, a substantially smaller trial and with shorter follow-up, but showing really the same thing. Their primary endpoint was distant metastasis-free survival, and they saw no hint of a difference based upon the same sort of trial design and intervention in that series. So it looks like it's a pretty robust result in terms of what completion lymph node dissection does or doesn't do. One thing that it does do is provide additional staging information, prognostic information for these patients. And so when we did multivariable analysis of the factors associated with survival, the observation group didn't have a completion dissection, so we didn't have that information, so we'll drop them out for the moment. And if you look at the patients that had completion dissection, the full set of staging information, things that came out as significant included what you might expect in terms of Breslow thickness and ulceration, but completion lymph node dissection status, so the non-sentinel lymph node pathology status, was also very significant in terms of the prognostic effect of having these positive non-sentinel nodes, as we had seen in the prior retrospective analysis of this. And actually, when you include that information into the model, the number of positive sentinel lymph nodes goes away, is not important. And so there is this distinction, this qualitative distinction between sentinel nodes and non-sentinel nodes, the nodes that are first in line in terms of the drainage from the primary site compared to all of the other nodes that are in a qualitatively different category. And so this is one of the issues that comes up as we think about not doing completion lymph node dissections in everybody anymore. How can we regenerate that information? The other secondary endpoints included disease-free survival, and there was a significant improvement in disease-free survival in the dissection group. And when you look at what's responsible for that improvement in disease-free survival, it comes really entirely from prevention of nodal recurrences. So there's a huge difference preventing nodal recurrences by taking out the nodes early, whereas if you look at distant disease-free survival, really there's no impact. The other interesting thing is this latent subgroup question, the patients, how many patients had non-sentinel node positivity. Interestingly, when you look at the two arms of the trial, it's not the same. It should be the same, right? It's a randomized trial. It should work out to be about the same. But if you look, the patients in the observation group, as early as about 3 years into follow-up, have an excess of non-sentinel node involvement, and that persists then out through the length of follow-up in the trial. And so why should this be the case? So I believe it's because there are a group of patients in the completion dissection arm whose non-sentinel node metastases are just missed. They just do a single H&E section basically of a whole bunch of other lymph nodes, and there's a decent chance that you'll not find a small metastasis, particularly when the sentinel node metastasis was so small. And this goes along with the Cochrane data that when you do IHC on the rest of the nodes, you pick up another 10% or so of patients that were positive that you missed, and that's about the same difference between the two arms of the trial. So I think that's probably the explanation for that difference, and it has two implications for what we do with the trial. One is that a straightforward latent subgroup comparison, which is what everyone asks for. Well, what if you just compare the patients that had positive non-sentinel nodes? Was there a therapeutic impact of dissecting them? It's not as easy to do that for this trial as it was for the prior MSLT-I trial because it's not apples to apples. And so we'll continue to think about ways of getting to a reliable analysis of that question as time goes on, but for the time being, it's not as straightforward as we might like it to be. The other implication is that when you're devising a scheme to predict patients that have non-sentinel node involvement, so if you're going to counsel a patient about whether or not they want to have the rest of their nodes taken out, you'd like to estimate for them the risk that they have other nodes involved. Well, if you're missing half of the patients basically that have non-sentinel node involvement, your prediction scheme for recommending completion dissection is potentially going to be faulty. One of the factors that almost always comes out in these analyses that look at non-sentinel node positivity is the size of the sentinel node metastasis. Well, if your sentinel node metastasis was, 0.5 millimeters, then there's a decent chance that if there was other disease in the basin, it's going to be a similar size and would have been missed in any of those prediction schemes. So it's another thing that we'll have to put into our pot when we're digesting these results over time. The nodal recurrence patterns were also different between the two, or the recurrence patterns in general were different between the two arms. And obviously in brown there are big excess in nodal recurrences in the observation arm, as you would expect. But when you break down those nodal recurrences by the other recurrences that were happening, or the specific types of recurrences within that group, most of the patients that had nodal recurrences, even in the observation arm, had other sites of recurrent disease when their nodal recurrences were detected. So either distant recurrences with their nodal recurrences, local recurrences with their nodal recurrences, or all three at the same time. So the group that actually had only nodal recurrences is not that large for even the observation arm in the trial. One thing people were very interested in was what about subgroups? So were there any subgroups within the overall population that seemed to derive more benefit from the intervention than the group overall? Our retrospective data had suggested that this same types of subgroups that had benefit in like the elective lymph node dissection trials were more likely to have benefit in this setting as well. Turns out not to be the case. So there were no subgroups that stood out as statistically significantly more likely to have benefit, and the groups that everyone thought might be more likely to have benefit, the ones that are more likely to have non-sentinel node involvement, either thicker tumors or patients with larger sentinel node metastases, did not have any hint that they were more likely to benefit. In fact, if you look at the question of the volume of tumor in the sentinel node, it's in the opposite direction to what you might suspect if there's any trend at all. So it was the patients that had the smallest amount of disease in their sentinel nodes that were trending on the side of in favor. So we don't, based on this, have a great subgroup to suggest an MSLT-IV for some other randomized trial for a specific subgroup. Other secondary endpoints, one of the interesting things was ultrasound. People were interested in ultrasound as a way of screening patients with primary melanomas to see if their sentinel node metastases could be detected prior to any intervention, and then biopsied by FNA and going straight to dissection. Results from this pre-sentinel node ultrasound varied an enormous amount across the globe, with really one site in Berlin having outstanding results, I think based upon the exquisite skill of the single ultrasonographer that was there doing it. The rest of the world had a hard time matching that. And certainly this trial bore that out. So pre-sentinel node ultrasound was very unreliable in terms of predicting sentinel node involvement, sensitivity of only 8%. More patients had false negatives than had true positives. Basically the problem was what we were asking ultrasound to do was beyond its capabilities. The size of the metastases that were detectable by ultrasound was an order of magnitude order of magnitude larger than what ultrasound could actually pick up. And then the last issue with pre-sentinel node ultrasound is that the assumption then was that you could just skip the sentinel node step and move on to completion dissection. But as the trial showed, it's actually probably the sentinel node part of it that's the really truly therapeutic part, and that you wouldn't necessarily jump to completion dissection even if you had an FNA that was positive on ultrasound. Follow-up ultrasound is a completely different context. So it's patients that are just getting physical exams and then other imaging at intervals. And this is adding ultrasound as a way of screening the nodal basin in addition to physical exam. So it's probably going to do better in this setting than it did in that comparison to histology, which is what the screening comparison was. This is just a review that John Thompson did of ultrasound in this setting, and you see that the sensitivity is much better here across these series than it was. So far, we don't have enough really follow-up to give a formal analysis of ultrasound in the follow-up stage here, but it looks like somewhere in the neighborhood of a third of nodal recurrences get picked up by ultrasound before they would be picked up by other modalities. So it does provide some additional information. How much that early warning adds to their overall clinical outlook is another question that we'll need to answer. And then the other big secondary endpoint that was part of the grant is looking at this RT-PCR assay. So it was a relatively advanced assay. It's done on paraffin-embedded sections, so you don't lose any of your standard pathology material. A multi-marker assay to try to avoid some of the false positives that were a consideration with some of the other prior PCR evaluations of nodes. This was the retrospective series from Dave Hoon's lab that showed two things. One is that if you had a PCR positive node in this retrospective series, you did just as badly as if you had a pathology positive node. And the other, on the flip side, if you had a PCR negative sentinel lymph node, you did extremely well. So those people could sort of you could tell them, go away, or you're fine. Unfortunately, it looks like it's not going to be borne out on the prospective validation of that assay. We're actually, at the moment, doing a formal analysis comparing the PCR positives to the PCR negatives, but if you just look at where all of the PCR positives in the randomization phase of the trial turned out, they did not turn out down here where they did in the retrospective series, and they're not coming out in the same prognostic category as the pathology positive group. So why there's that discrepancy between the retrospective and the prospective is, I think, unknown at the moment, and we'll look into that, but another reminder that prospective clinical trials are essential for getting to as close to the truth as you can. So to give this some context, because this is a controversy that stretches back well beyond my years, beyond anybody currently alive, and the issue is it seems very obvious that a primary tumor, most solid tumors spread to lymph nodes, and then from lymph nodes they spread to distant sites. And so there's this period of time while the tumor is growing in the lymph node before it spreads either to other lymph nodes or to distant sites, where if you can intervene and take out the disease in the node, you'll save that patient. Those patients will do better. If you look at just very high levels, sort of SEER summary data on how tumors present in the United States, if you present with metastatic disease, which are the yellow wedges and brown wedges, the yellow wedges are bigger than brown wedges. So when you present with metastatic disease, most of the time it's nodal disease, not distant disease. So it seems logical that there's this progression, this sequential progression from the primary site to nodes. And if we look at MSLT-I, which is a randomized trial comparing just wide excision at a primary site to nodal intervention of any sort in the form of a sentinel node, and if you compare patients that had early treatment of their nodal metastases versus late treatment of the nodal metastases, the early treatment patients, the number of nodes that are involved is half that of the group where you waited until they recurred clinically and took them out then. So clearly it spread from the initial node to other nodes over that 12 to 24 month period of time while those patients were being observed. So there is this sequential progressive movement from one node to the next, at least. And nodes go way back in melanoma. So the very first melanoma case presented by John Hunter is actually a node of metastasis. It is a central component of the disease. And Herbert Snow, who was a surgeon at the London Cancer Hospital, a forerunner to the Royal Marsden, started this controversy really by suggesting early treatment of lymph nodes in melanoma. That's his operating room, that's his publication from The Lancet. And he said in that publication that it is essential to remove, whenever possible, those lymph glands which first receive the infective protoplasm and bar its entrance into the blood before they have undergone an increase in bulk. This anticipatory gland excision, a simple common sense measure, adding nothing to the gravity of the surgical operation while most materially enhancing its efficacy. So that is the elective lymph node dissection controversy in a nut right there that then raged on for a century thereafter. And the issue was the actual experimental clinical evidence that followed that when this question was eventually asked in randomized trials didn't bear out this obvious finding that the lymph nodes are a critical component. Getting away from melanoma for a moment, the BO4 trial in breast cancer, super long-term follow-up, no difference in outcomes based upon either radiating or taking out lymph nodes in the axilla. Bernard and Edwin Fisher in the 60s did experiments where they injected tumor cells into the footpads of rabbits, and when they did this and then collected the effluent lymph that was beyond the popliteal lymph node, there were lots of tumor cells that went just right through the node. So the nodes were clearly not acting as mechanical filters for tumor cells, which is how we sometimes think about it. That's not how they work. And then other randomized trials in other diseases, esophageal cancer, lung cancer, showed no statistically significant benefit to increased nodal intervention compared to lesser nodal intervention. It's important to note that these are not comparisons of no nodal treatment to nodal treatment. It's some nodal treatment to more nodal treatment. So it's not exactly a clean scientific comparison, but no significant difference. Another famous trial, the Dutch gastric cancer trial comparing D1 lymph node dissection to D2 lymph node dissections, no difference in survival there. And so this then led some to be able to conclude, here's Blake Cady in the Annals of Surgeonc with an editorial saying, data demonstrate no statistically significant difference in overall survival in patients treated with or without lymphadenectomy. Overall survival is primarily a function of the biological nature of the primary tumor, as evidenced by lymphovascular invasion, et cetera, et cetera. So his conclusion is that lymph nodes don't matter. And then this sort of became the received wisdom that lymph nodes are really just about staging. So why is this? Why is it so obvious, but it doesn't work out the way that we thought it was supposed to? And for fear of having several excuses, I'll give you a few reasons. One is that in some instances there was added morbidity, mortality related to the intervention itself. A lot of it has to do with statistics. So many of these trials were quite underpowered. And when you think about when you would expect to see a survival difference based upon lymph node intervention, it's later in follow-up. So it's patients that have disease in the nodes but not distant yet, and you've prevented it from spreading, so it takes a while for that to emerge. When you think about a log rank test, that sort of favors early effects rather than late effects. And most patients have negative nodes. As you saw, lymph nodes are not physical filters for tumor cells, but I think I'll be able to convince you, hopefully, that they can be incubators for tumor cells. And then biology is king. And so I think that the timing of the intervention, surgical intervention in lymph nodes matters, but it doesn't matter for everybody. So the Dutch gastric cancer trial, obviously, as you saw, no difference, but there was an excess of operative mortality in the D2 group. And if through the magic of PowerPoint you eliminate that difference, the survival curves look very different. And so they actually did this in a legitimate way and looked at gastric cancer-specific mortality in a subsequent publication, and there is a big difference. So if they survive the operation, then you begin to see this difference on a biological basis based upon the nodal intervention. And although all of these trials in lung and esophageal cancer, there was no difference, statistically significant difference, in all of these instances, the group that had the increased lymph node intervention did better, just not statistically significantly better. And getting back finally to melanoma, it's the same way in all of the melanoma trials that looked at nodal treatment and no nodal treatment. There was no statistically significant benefit, but in all of the trials, the group that had the nodal intervention was on top. So to some extent, I think it's a matter of, you can argue either side of the point based on this information. So many have. It's only a subgroup that can benefit from lymph node dissection. Most patients with melanoma only have primary disease. Taking that out cures them. And so they can't benefit from lymph node intervention. Others already have distant disease, so they can't benefit from nodal intervention. It's only this intermediate group where you can see potentially a therapeutic effect of the lymph node dissection. But if you think about doing a trial in which the vast majority of the patients you're going to enroll in the trial can't possibly benefit from your intervention, it's going to be hard to get a statistically significant result. So MSLT-I, again, this is the trial that compared wide excision alone of the primary to wide excision with sentinel node. If you had a positive sentinel node, everybody got a dissection in that trial. And this was the final result. No statistically significant benefit to sentinel node in that group. But if you think about it, and this issue with the majority of patients in the randomized groups can't possibly benefit from the intervention, but you concentrate your evaluation in the group that actually had occult stage 3 disease on presentation, so either detected by disease recurrence in the nodes or by a positive sentinel node. If you compare those groups, then there's a big difference in outcome. So nearly halving of the melanoma-specific mortality based upon removing these metastases early rather than removing them late. The problem with that comparison, of course, is that they're not randomized into those groups. And so the question is there some bias that gets entered into this comparison that you can't account for? If you look at their characteristics from a prognostic standpoint, they're all the same in the two groups. And if you look at the overall fraction of patients that have nodal involvement detected by either of those means, it works out to be about the same. So for the intermediate thickness group, over time, here's the positive sentinel nodes, and then over time the recurrences in those basins. And this is the observation arm, the patients that recur over time. And if you have enough follow-up, the curves come together for that group and for the thicker group. And just to remind you what it looks like when they don't look the same, this is MSLT-II, the same sort of latent subgroup question. So I think that really it's the same two groups that you're comparing when you're comparing the node positives in the two arms of the trial. That does not satisfy statisticians. Fortunately, we work with some good statisticians, the Elishoffs, who developed a methodology to really validate this latent subgroup evaluation. And it was pretty intuitive, I think. That's what you would have guessed. That's what they would have gone with. But basically, this runs a number of simulations of the data to try and account for variables that might introduce a bias. And we'll take their word for it that when you do this, it does demonstrate that for the intermediate thickness group, there is a significant impact on their outcome for the node-positive patients to having that disease taken out early rather than late. What about this issue of the filter? The question of lymph nodes as filters. They're clearly not filters, but you don't have to be a filter to play the role of an incubator for metastatic disease. And lymph nodes, we now know, are clearly prepared for the arrival of metastases in ways that the rest of the body is not. So there's lymph angiogenesis that occurs not only at the primary tumor site, but within lymph nodes. And if you compare non-sentinel lymph nodes to sentinel lymph nodes, there's this ingrowth of lymphatic vessels that will facilitate the arrival of metastatic cells to that node, and it occurs even before the disease gets to the node, so it's prepared for their arrival. There's also selective immunosuppression of tumor-draining lymph nodes compared to other nodes. So this is Cochrane's work again, where he looked at the area of the node occupied by dendritic cells. And in non-sentinel nodes, there is this robust area of dendritic cells. When you look at the cells at high power, they have these long dendritic processes, and they're actively taking up antigen in the node. If you look at a sentinel node that's directly draining the primary tumor site, that dendritic cell area has largely gone away, and the dendritic cells have been pruned, suggesting that they are no longer in their active surveillance mode. And these findings have clinical implications. If you look at melanoma-specific survival, or here, melanoma-specific survival, if you have a preserved dendritic cell network, that survival is better than if you've lost your dendritic cells in this analysis. The other thing that happens is it leads to more non-sentinel node positivity if that initial line of defense at the sentinel node has been lost. So the sentinel node and the lymph nodes in general are probably, to some extent, a privileged location. And you can think of it almost as an extension of the primary tumor site. It's an area where it's easy for the tumor cells to get to, open-ended vessels, not a lot of shear forces in the lymphatics, immunosuppression of the node, compared to trying to get into the bloodstream, get out of the bloodstream, survive the turbulence there, and survive a preserved immune function in the rest of the body. There's this sharp distinction between the two areas. So in the end, biology is king, and not my phrase. I think Blake Cady may have come up with that phrase, but there are some groups that probably benefit from this early intervention and some that do not. And this is not new information either. So this is data from Charles Balch from retrospective analyses in Alabama when he was planning the elective lymph node dissection trial and who should be enrolled in that trial. And if you look at the thins, both for the type of metastases that people have, for thin melanomas, everybody does fine, everybody survives. If you look at thick melanomas, everybody's got metastases and everybody's going to do poorly, and intervention doesn't matter. And it's really this intermediate thickness group where you would expect to see some benefit. It's the time point when you can intervene and make a difference from a surgical standpoint. When MSLT-I was being planned, the same analysis was done on the John Wayne database and showed the same thing. The thins, everybody does okay. The thicks, it's a bad situation no matter what. And it's in the intermediate range where you begin to see this difference between outcomes. And actually, when you look at the randomized elective lymph node dissection trials that were done, it didn't come out when these were initially published, but there is some indication that this is true in those trials as well. So this is the figure from the WHO-14 trial, so patients randomized to nothing or complete dissection from the outset, and no statistically significant difference in favor of dissection. But when you break down by thickness what the outcomes were, which they were not allowed to do in the initial publication because it was a subgroup analysis and they didn't want to have a subgroup analysis in the paper, but this is in Balch's textbook. If you look at the intermediate thickness group, there is a statistically significant benefit for intermediate thickness and no indication of any benefit at all for the thick patients. Balch's intergroup trial, same sort of thing. For the intermediate 1 to 2 millimeter thickness here, there's a significant benefit as well as these other substantial subgroups. And if you look at a MSLT-I trial, this is that same curve comparing the node-positive patients with the big difference. This is the intermediate thickness group. If you look at the thick group, no difference at all. And so this biology just repeats itself in study after study, where in the thick group you may get prognostic information from the nodes, but there's no survival benefit that will come from it. But there does seem to be this reproducible, somewhat reliable benefit for early intervention in nodes for the intermediate thickness group. Where does MSLT-II fit in this? I think MSLT-II, the non-sentinel node patients, may essentially be patients who are like the thicks. So if you've had disease penetrate through that first echelon of your nodes, you're into this high-risk category, and early intervention may not make a survival difference. And then the last group, probably the most important group and probably the most controversial group, are the thin patients with thin melanomas. And most of them don't have any disease in their nodes. And so you could never do a randomized trial of that, try and ask the question of early intervention for them. And it wouldn't be appropriate anyway, because a lot of those patients, their risk of nodal involvement is less than 1%. But in collaboration with the University of Pennsylvania, we looked at patients who had stage 3 disease with thin melanomas, either detected by sentinel nodes or detected on recurrence later on. And it's roughly the same proportion of patients that are in those groups for thin melanoma patients controlled for thickness. And the sentinel node group's the blue line, and the The group with thin melanomas but with nodal recurrences clinically is the yellow line. So this is the largest difference that you see for any of the thicknesses. And obviously there's the potential for bias. We did a matched pair analysis that looked at pairs of patients matched for prognostic variables in these within these thin groups, and no difference there. And when you look at the Penn data and the John Wayne data, it's exactly the same on opposite sides of the country. And it makes sense that if you have a thin melanoma, they're the least likely to have distant disease at presentation. So early intervention for the nodal metastasis there probably makes the most difference. The challenge is figuring out which of the thin patients that you should operate on. So to put this all together, intermediate, that's where you see this big difference. Thicks, no indication in any study of a benefit for early intervention in the nodes for thick melanomas, and then this hypothesis anyway about the thins. So I think this is probably true, this incubator phenomenon, but it's not true for everyone. So application of the MSLT-II result to today, completion lymph node dissection remains an option. So some people have sort of concluded we're done with lymph node dissections. I don't think that's true. You still clearly get staging information for these patients, which is potentially very important now that there are adjuvant therapies that are effective, but have toxicities. Patients may want to be able to weigh what their risk of recurrence is before they make that decision. There are obviously downsides in terms of morbidity to the procedure. And you have to put in caveats because no trial is perfect. If you're going to observe patients, you have to observe patients. You can't just send them out and wish them well. They have to come back for regular follow-up. We have limited numbers on the quote-unquote high-risk patients, so that's been one of the criticisms of the trial, patients with larger metastases. Frankly, I didn't get any sense that they're more likely to benefit, but that is something that you need to bear in mind. And then the last and most troubling question that we've gotten about the trial is when people react to say, there's no survival benefit, so we're not going to do sentinel node biopsies anymore. It's actually the opposite conclusion is the appropriate conclusion. What this seems to indicate is that the therapeutic part of the procedure, if there is a therapeutic effect, actually probably comes from the sentinel node procedure rather than the completion dissection. And that you can avoid the majority of regional recurrences in melanoma patients just by taking out the sentinel node, even if you leave the other nodes behind. And so if anything, your reason for doing a sentinel node biopsy is stronger now than it was before. So what else do we need to do? There's lots more work to be done. We need to be able to see if we can replace this prognostic information from the completion dissection with some other variable, potentially the volume of disease in the sentinel node, potentially molecular profiling, improve prediction of non-sentinel node metastases. We don't have very good schemes for doing that now. And if you could tell somebody you've got a 90% chance of having a recurrence in your basin, they'll probably want to have the dissection early rather than late. There's a fascinating laboratory within the sentinel node for evaluating interaction between the primary tumor and the immune system. It's the first place those two things come together, and so it's a rich resource potentially for additional data and insights into how tumors affect immunity. Decreasing morbidity of the nodal dissection, potentially through minimally invasive approaches for the groin or other ways of doing that would be an important contribution. And then probably most importantly, figuring out which ones of the thin melanoma patients should have a sentinel node biopsy, should have an intervention, will be a critically important question. So all this work comes from many, many people. Obviously, the trial was an enormous undertaking. So just to recognize the DSMB, our pathologists and statisticians, clinical trials people, and then all the investigators across the world that worked on this. But the most important person to recognize for this is Don Morton. His conception of the sentinel node biopsy, his tenacity to get these trials underway and run is really a testament to what surgeons can do. I think he serves as a tremendous role model to us still, as he has from Dr. Goodnight's time, from my time, and for all the young people here as well. So thanks very much.
Mark, that's great. And it's such an illustration of the importance of the role of randomized clinical trials, because I think the expectation was that the results were going to be different. And so doing the hard work and
Yeah.
appreciating it is a really important thing for all of us to do. And it's becoming particularly relevant to us here in Northern California. I suspect it's true in Southern California, but the incidence of melanoma definitely appears to be rising. And across the age spectrum is the sense that we're seeing here. It was sort of, we thought it was important that we have a melanoma specialist surgeon here, and then all of a sudden, they seem to be coming out of the woodwork.
Yeah.
And so this kind of thinking about what's the right thing to do is really important.
Yeah.
So thank you for helping us think carefully through the results of this trial.
Sure.
It's really important. And we have a few minutes for questions. I have one question about the side effects and lymphedema, but let's start with Dr. Goodnight.
Well, Mark, thank you for coming. An extraordinary summary of work over about 4 decades, and that's incredible. So the effort and persistence to do a trial like this is amazing. Don Mark was a giant, very hard-driving man, determined to cure melanoma, to cure it with immunotherapy. But he developed this sentinel lymph node biopsy. I used to tease him, but in all seriousness, I said, what you'll be remembered for is the sentinel lymph node biopsy, which is proved to be an enormous laboratory for studying this disease. And so I was jotting down questions you kept answering one by one. So I'll say that, but just comment. Thank you for being here. Yes, the importance of the disease. It remains a disease you don't want to have.
Dr. Moore he was at UCLA at the time, and he was working on the 2 big things were the sentinel node and the vaccine. And the university decided it didn't want to develop intellectual property rights for either one. So he had to decide, he was going to do one of them on his own, develop his own system for that. And so he had to decide he couldn't do both. So he decided which one he was going to do, and he chose the vaccine and worked out the other way.
So it shows both the occasional lack of wisdom of institutional knowledge about what's important, and when you gamble, you can win and you can lose. So, talk to me a little bit about the issue of lymphedema and the side effects of completion node dissection, because you made the comment that despite the relatively powerful data, that it might still be an option in certain circumstances. But how do you weigh that against the risk of complication?
Yeah, I mean, so most of the morbidity of lymph node dissection is transient, infections, seromas, those sorts of things, and they're not that common. Lymphedema is really the thing that people worry about. Lymphedema is somewhat less common in melanoma than it is in breast cancer for reasons that I think we don't fully understand, whether it has to do with radiation that often accompanies the breast cancer treatment or chest surgery at the same time, things like that. But it does seem to be substantially lower, but it still is an issue. And we don't have a great way of predicting who will have that complication. There are associations, but nothing that is terribly strong. And although it's treatable, it's generally permanent. So what could be done to reduce that risk? We've moved now to doing videoscopic minimally invasive groin dissections. That's the highest risk basin to deal with. The risk obviously varies by basin.
Do you think that's better? Do you think that reduces risk?
It is clearly better from an acute morbidity standpoint. And so we don't really worry about flap necrosis. Cellulitis is not the issue that it once was with the open dissections. That's clearly better. Patients still get lymphedema. Whether the rate is less, it may be because the late complications are associated with the early complications, but it's clearly not going to eliminate the problem. There are moves to do things like lymph node transplants and lymphovascular anastomoses and things like that, either as treatment or prevention for lymphedema. And unrandomized series reports suggest that it's beneficial, but we'll have to wait and see, I think.
So one of the big common buzz phrases right now in oncology is precision medicine. And you kind of got to the end of that, which is that some of the intermediate thickness is the group that may be most likely to benefit from a surgical intervention. A long history we've had from Halstead, which is surgery is really the primary mechanism of survival benefit by getting beyond the leading edge. but that's still an anatomic definition. And how are we really going to get to biologic definitions for the implementation of precision medicine, identifying those patients who the lymph node is really not the gatekeeper, it's not anything, but it's simply reflective of biology that we could have perhaps gotten from the primary. How do we get there?
You have to assume it's going to come from molecular information. There are gene expression profiles that are commercially available and others that are in research development, and those may suggest not only an overall prognostic impact of some of these molecular signatures, but potentially the mode of spread of a particular tumor, whether it is a nodotropic or not sort of tumor. But as far as I know, there isn't, other than the histologic anatomic information, there isn't a replacement that's about to be available, I think.
Can I follow up with a question? There are some things that, and I think you kind of hinted at it, which is the interpretation of some trials. There are genomic signatures that have been promoted by some companies that can predict your melanoma-specific survival, and some people adopt those. The dermatologist adopted the MSLT-I trial and said no patient needs to see a surgeon anymore because sentinel lymph nodes aren't really important in the management of disease. How do we move to the implementation of data into clinical practice in a relatively fair, equitable fashion?
Yeah, I mean, I think it's a big challenge because we don't all listen to each other, and people carry their biases into how they interpret results, and the biases will be confirmed by a lot of these results. I think there has been an effort on the part of organizations like the SSO, like ASCO, NCCN, to develop guidelines that then are a firm foundation by which people can choose how to treat their patients. And one hopes that guidelines will be enough, that it won't require some heavier hammer to get that to happen. But that's a relatively recent thing, I think, this reliance on guidelines, and I think it has yet to come to full maturity, and so hopefully we'll get there with that.
Dr. Klein, you have the last word here.
So I have two questions. I'll save the rest for last. First is, I'm wondering what you think the context of completion dissection is now that we're finally in a post-kidney era and our oncologists are willing to treat unresected 3A disease with nivo and BRAF inhibitors. And the second is for the residents. I can tell you last spring, when I was studying for my general surgery boards as a disciple of Dan Coy, I literally had nightmares that he would examine me about completion of commitment. So if they can speak eloquently about MSLT-II, is this finally safe for the hotel room for our students?
Yeah, I think it's not a great board question.
That doesn't seem to.
Criteria. So yeah, I mean, it's yet to be seen. What I've heard about the Surg-Onc boards anyway is they may require some maturation themselves the way the exam is given, but because it's brand new. But I don't know. I think maybe not. It may not be. We may not have had enough time to digest this information that there is a safe answer necessarily. So you probably want to look up who your examiner is and see what their bias is. So if it's Dr. Coit, you'll know what the right answer is. But he and I will debate this issue at SSO this year. So the advent of the effective adjuvant therapies changes the world in terms of melanoma, but it probably increases the value of the prognostic information of this the intervention. Each of the available therapies is going to cost well over $100,000, so not a small investment, potentially with irreversible side effects from an endocrine standpoint, and other potential severe side effects. So people may want the information to decide. They may be willing to accept the risk of lymphedema in exchange for that.
Impressive. That's a we aren't accustomed to taking issues like cost into making personal healthcare decisions, but I think that is starting to become more of an issue. Thank you again. Really great.